The Patihis and Lynn article from 2017 first explains how the Dissociative Experiences Scale 2, often referred to as DS2, has been widely used to measure dissociative experiences, but it has some notable limitations. One of many issues with the DES2 is its tendency to produce skewed results due to floor effects in general population samples. To address this limitation, researchers in 1999 developed an alternative measure called the Dissociative Experiences Scale Comparison, or DSC. The DSC was designed to reduce floor effects and provide a wider spread of scores, particularly in non-clinical samples. While the DES2 asks participants to rate the percentage of time they experience dissociative symptoms, the DSC requires participants to compare their experiences to those of others. However, Dallenberg and colleagues in 2012 excluded studies using the DSC from their meta-analysis, arguing that participants may lack the ability to make accurate comparative judgments. Lynn and colleagues in 2014 argued that the DSC research should not be excluded from literature reviews, as it correlates with measures indicative of validity such as fantasy proneness, intrusive images following trauma exposure, and risk for self-harm. Additionally, several studies have found associations between the DSC and various types of memory distortions, which are relevant to the socio-cognitive model of dissociation. The Patihis and Lynn 2017 study indeed found that the DS2 and the DSC had about equal psychometric properties, thus confirming the idea that Dallenberg et al. 2012 should not have excluded studies using the DSC. But the study also revealed that the validity measures, for example the correlation between trauma and dissociation, were remarkably low. As shown in Table 3, the overall correlation between total trauma scores on the Traumatic Experiences Checklist, TEC, and the Dissociative Experiences Scale 2, DS2, was R equals 0.16, while the correlation with the DS comparison, DSC, was R equals 0.22. If you look at Figure 2 in the article, the scatter plot illustrates well how many exceptions there are. In other words, many individuals scored high on trauma and low on dissociation, and some scored high on dissociation and low on trauma. This illustrates that if clinicians measure a patient's dissociation scores, it tells them little about whether the person was traumatized or not. Sadly, trauma and dissociation therapists are uncareful in this regard. These correlations are considerably lower than some reported in previous research, with one claiming R equals 0.61 in clinical samples and another R equals 0.40 in non-clinical samples. Often this previous research was collected by researchers who heavily believe and are heavily motivated by the theory that trauma causes dissociation. In some past samples, the participants also have been taught this theory, which may skew the results. Looking at specific trauma types in Table 3, the correlations remain small or negligible across the board. For emotional neglect, the correlation was R equals 0.23 with the Dissociative Experiences Scale. Emotional abuse showed a correlation of R equals 0.12 with dissociation. Some correlations were not statistically significant and were tiny. Physical abuse correlated negligibly at R equals 0.08 with dissociation. Sexual harassment had a correlation of R equals 0.03 with dissociation. Finally, and perhaps most importantly, sexual abuse showed correlations of only a tiny R equals 0.03. These low correlations indicate a very weak relationship between trauma and dissociation. To put this in perspective, even the highest correlation in Table 3 of R equals 0.27 means that trauma explains only about 7% of the variance in dissociation scores. This suggests that over 93% of the variance in dissociation is explained by factors other than trauma. When it comes to sexual abuse, less than 0.5% of that variable explains the variance in the dissociation variable. In other words, more than 99% of the variance in dissociative symptoms is explained by other factors that are not prior sexual abuse. Such low and negligible correlations challenge the notion of a strong causal link between trauma and dissociation. The study challenges the very idea that the dissociative experiences scale should be used to try to retrospectively guess at whether a psychotherapy client has past trauma, especially sexual abuse trauma. Even worse would be to assume a client had hidden trauma that needed unrepressing. This could lead to iatrogenic therapy that unnecessarily traumatizes the client and induces symptoms arise from false beliefs and memories of traumas that in fact did not happen.